Chapter 2 is all about medical records, and the reason that this is important is that this is how your textbook is organized. Each different chapter about each different body system will have terms that relate to specific sections of medical records. So in this video, I'm going to talk about the functions of medical records, the organizations and the parts of medical records, and the common terms associated with each one of those parts. And then at the very end, I'll just show you quickly a couple examples of medical records. There are a lot of different types of medical records. So the function of medical records, sometimes you'll still see them in paper. Increasingly, they're electronic, and they contain all the information that a medical professional needs to know about that patient when they see them. And depending on the different type of medical record, they may contain different kinds of information. Commonly, they'll have some medical history, the patient's previous illnesses, what kinds of treatments they've had before, have they had surgeries, are they allergic to medications of any type, are there any continuing medical issues that they're dealing with, say ongoing diabetes or recurring asthma. They'll also include family medical history because a lot of diseases and disorders are hereditary or at least have a hereditary component. So knowing family history can help diagnose the symptoms the current patient is suffering from. And as I mentioned before, any current medications they're on, either prescription or what's called over-the-counter, OTC. That would include aspirin and antihistamines, but it would also include any kind of herbal remedies that the patient may be taking as well. Medical records have a set organization that they follow so that each medical professional that sees that patient knows where to go in the medical record to find the information they need at that moment. Not all medical records will have all of the information. For example, a prescription is technically a medical record, but it's not going to contain the medical history or continuing medical issues or family health history. It's just going to say how much and how often this person needs to take that medication. A lot of medical records will have most of these sections to them. So this is how they are organized. We use the acronym SOAP to describe it. You may have heard this before, so forgive me if you already know this. S stands for subjective information. O stands for the objective information. A is the assessment of the patient at that moment. And then P is for where do we go from here? So what kinds of stuff do you find in the subjective? Well, basically, this is the kind of information that the patient brings to the medical professional. I have a stomach ache. I have a headache. I can't see straight. I'm having trouble hearing out of this ear. It's what the patient provides. So it's their subjective expression of what they're going through. In the medical record, then, it's the medical professional's job to take that information and translate it into medical terminology so that anybody else, any other medical profession who reads that record has a firm understanding of what that patient is going through, what they're experiencing, but in a medical terminology way. So, for example, a patient may say, I've had a runny nose for the last few days. Well, in the medical record, you would see it written as the patient is presented with acute rhinorrhea. So acute meaning it's sudden onset, it just came up. And rhinorrhea, as we saw before in previous, rhea means to flow, rhino means to nose. So that's a runny nose. These are some common subjective terms. Acute versus chronic. Acute means sudden onset, it just happened. Chronic means it's ongoing and has been occurring for a period of time. Again, abrupt means they had an abrupt loss of hearing. It wasn't like they slowly got deafer and deafer. They had an abrupt loss of hearing. These are two of my favorite words, febrile and afebrile. Febrile means that they have a fever. Afebrile means they don't have a fever. Of course, fevers can be caused by a lot of different things, and it's a common complaint, so that's why it's a common subjective term. Malaise means they feel blah. They just don't have any energy. They don't feel like doing anything. Ugh. Of course, progressive means that it's getting worse. It's not just chronic, where if it's just chronic, then it's been going on for a long time, but it's been the same. Progressive means it's getting worse and worse and worse as time goes by. Exacerbation means that some event caused it to get worse. Like, I've been having this pain in my knee, but when I went skiing the other day, wow, it just really got worse. So the skiing exacerbated the knee pain. Something can be non-contributory. So if somebody comes in and let's say they're having trouble breathing, they're wheezing, and they say, "Oh yeah, and I've got this mark on my leg." Well, if that was an insect bite, it could be contributory. It could be causing the breathing problems. Could be an allergic reaction to that insect bite. Or if it's just a bruise, they banged their knee against a desk or something, then that would be non-contributory to the breathing problem. Lethargic, kind of like malaise, they just don't have the energy to do anything. They have trouble getting up and getting moving. And of course, I think you know genetic or hereditary means that there's a family history of this sort of thing occurring. For the objective portion of a medical record, that's where you get the facts, the hard data. You're doing measurements, you're making concrete observations, and then recording them in medical terms. So you'll use the medical terms for the procedures that were done and for the data that was gathered. In an ordinary, average checkup with your general practitioner, you're going to have your height, your weight, your heart rate, and your blood pressure all measured in the doctor's office, and that gets recorded in the objective portion. The other part that goes in the objective portion would be any kind of observations that the provider makes. So they may notice that you're limping, or they may notice that you're having trouble speaking. And they are going to record that in medical terms so that if that medical record is read by some other medical professional, they know exactly what's going on. If your general practitioner sends you out for blood tests or urinalysis or x-rays or something, when that information comes back to your GP, it would be recorded in the objective portion. So this is all about the data. Some general terms that you find in the objective section: the patient was alert. In other words, they were responsive. They could answer questions. They were there. Oriented means that they knew what day it was. They knew where they were, who the president was, that kind of information. Osculation refers to listening to something. So on osculations, the lungs sounded congested, something like that. Percussion is what it sounds like. You're tapping on some body part, you're pressing on to listen to the sound. So usually percussion involves osculation as well. A palpation is a feeling. So when you take someone's pulse, you're palpating for a radial pulse or a carotid pulse. You can palpate the abdomen. If something is unremarkable, ironically, you still have to mention it. So you might want to say, like, you palpated the abdomen, but it was unremarkable. Or you palpated the abdomen and there was marked rigidity. So unremarkable means that it was normal. Yes, you had to remark on it to say that it was normal, but at least the next provider knows that you did that test, that you actually felt the abdomen and it was normal at that point in time. So you still have to remark on the fact that it was unremarkable. And of course, marked means there was a marked rigidity in the abdomen. It's significant. This is not normal. Now, the next section is the assessment. So based on what your patient told you in terms of what they're feeling and the objective portion, the data that you've collected, you're going to draw conclusions as to what's causing that problem. And this is known as the diagnosis. And again, we've talked about this in a previous video, but dia means through and nos means to know. So this is to thoroughly know what's happening or to know through the problem. If at that point in time you're not sure, then you may give what's known as a differential diagnosis, which covers the most likely causes. So this could be caused by the flu, or maybe it is a bacterial infection, and I need to have blood tests run before I know specifically what is causing this particular set of symptoms. So general assessment terms, an impression, so you don't necessarily have solid data for something, but it's your general impression of what's going on. Of course, we just talked about diagnosis and differential diagnosis. Benign is typically used in reference to a tumor that is not growing very quickly and it's staying put, so it's going to be easily treated and it's not likely to lead to further problems or death. A malignant tumor, on the other hand, is growing quickly and it's spreading throughout the body. It's not staying put, and that puts you at much greater risk of death. Degeneration, I think you can figure out, and things are deteriorating. Etiology versus idiopathic. So etiology is the study of what's causing things. Where is this coming from? Idiopathic, this idio comes from the same root we get the word idiot. And it literally means not knowing what's causing the disease. Sometimes things can go into remission, which means the symptoms abate and it seems to have gone away. But they can be recurrent, which means it's come back, it's reemerged. Morbidity is your risk or your odds of further illness or disease. Mortality is your odds or risk of death from this problem. The prognosis, we get that root again, to know. This means to know going forward. So what's going to happen in the future? What do we think the most likely outcomes are? Your prognosis is with the proper medication, you should make a full recovery, or the prognosis is you'll never walk again. But what is your outlook? And that may involve mortality and morbidity. What are your risks of dying from this? What are your risks of further complications or diseases? If something is localized, like an infection is localized to a finger, or is it systemic and generalized? It means body-wide. Occult sounds evil, but it's not. It's just hidden. Anything that's hidden. A pathogen, as we talked about in a previous, means something that is capable of generating a disease. So it's a bacteria, or it's a virus, or it's a fungus. It's some living organism that's causing that disease. A lesion is any kind of tissue damage. Sequela is singular. More often they find sequelae are things that are caused by the original problem. So let's say you twisted your ankle, and so you started limping. That's the original problem. A sequela may be that you have hip pain as a result of all that limping. Pending, I think, we're waiting for results. We're waiting to find out what's going to happen. The next section is the plan. Where do we go from here? So based on the assessment, the diagnosis or possibly differential diagnosis, what do we recommend going forward? That could be as simple as you're fine, go home, or it may be a prescription for medication or a referral for surgery or a referral for further tests. Dial in a differential diagnosis into a single diagnosis. It can mean a lot of different things for that plan. A disposition is what was the outcome of today's meeting? Did I admit you to the hospital for testing? Did I refer you to a radiologist for a CT scan? Where did we leave it, basically, is what that means. When you discharge something, now in this context, discharge means you're let go from the hospital, you're discharged from the hospital. In other chapters, a discharge usually means some sort of fluid is leaking. But in this context of a plan, it means you're released from the hospital. Prophylaxis means to prevent. So you may have prophylactic medications to prevent something from occurring, from getting a disease. You see this commonly used in terms of contraception. To prevent a pregnancy, you use prophylactics. Palliative means you're treating the symptoms because the underlying disease is beyond treatment. So you're basically making them feel better until either the disease goes away, your body fights it off on its own, or it kills you. You may admit somebody to the hospital for observation. So you're not sure what's going on. You just want to watch them for a while under a close, medically competent environment. You're not ready to send them home. Reassurance, you reassure the patient. You can say, hey, yeah, I know this, you're feeling really bad, but it's a viral infection and antibiotics won't help you, but you'll feel better in a few days. You just reassure them that you know what's going on and that they're going to be okay. Supportive care is basically like palliative care. You're helping them, say supportive care could be putting them in a respirator to help them breathe while their body fights and the medicine gets a chance to work to cure them before they can be taken off of that supportive care. So here's an example of a clinic note. This patient, Tammy Jones, went into the clinic, and because of HIPAA regulations, they blurred out all the good stuff. But here in the subjective portion, the S portion, is their history. So what kind of medications they're on, what kind of allergies they have, and where did they report that day? So they reported they've been having whatever the symptom is for 5 days. And they also reported this symptom. She denied that, she had, done illicit drugs. but she does have a family history of this. So all of that is information coming from the patient. The objective portion, that's your data. So what was her temperature today? What was her heart rate, respiratory rate, overall impression of how they looked, all this different kind of data that got recorded during that. The labs and the radiology, she may have been referred previously to get those tests done, and this is the results of those tests. So based on all of these, from the subjective and the objective, they made a differential diagnosis. You'll note there's two things here. They're not sure which one it could be. So the plan probably is get some more tests to narrow this down to one diagnosis and follow up in 3 weeks once that the results of those tests are back and can be entered into the objective portion. This is a consult note. So this patient, Elijah Meads, had been referred to a specialist. You see there's an objective portion. This is what the patient originally presented with, what their symptoms were, and how they have been treated in the past. This is what the specialist did. They took x-rays. The data showed this, and the labs showed that. And then the assessment portion says that I think this is the diagnosis. And so the plan for going forward is to do this. And the disposition is he'll return in 2 months. There are lots of different kinds of consult notes, and this chapter in your textbook goes over a number of different ones you may want to take a look at. Chapter 2, I want to emphasize, this also contains information about the planes of the body, sagittal, horizontal, things like that, as well as definitions for various medical professionals. I think you can cover that on your own, but remember that you're going to be responsible for that on the exam. So the next video that you'll get to is chapter 3, where we actually get into the organ systems of the body.